point in time, if you have a good surgeon to operate and remove this valve, put a surgical and revascularize. So TAVI.
But let me, sorry to interrupt, sir. Such patients, they will never be good candidates to Dr. Ramakant Panda might operate on these patients, but these patients will never be good candidates for a redo cabbage also. If somebody is not a good candidate for a second time AVR, they are not good candidates for a second time. So what we have achieved in the 60-year-old post-cabbage is what Anant wanted: no PVL, no pacemaker, single-digit peak rate.
Fantastic. Yeah.
I think I congratulate Ravindra, and even at the age of 60 with the post-bypass, this is a good case for TAVI. There's no doubt for surgery. My question is different. I wanted to regarding the operative steps you had. So you had VT and VF and almost rest.
Can you put Iva's slide on the screen, please?
And it was of course very daring, and you were not losing your cool, and you were doing still. You knew that something is going to come back. My question is, the post-dilatation also you had another similar episode. This amount of PVL can be avoided post-dilatation in such cases where you have already had a almost cardiac arrest situation during time of implantation.
Very relevant question. Should you be scared of a first outcome which has happened and it might happen again? You should know the reason. You should know the reason why this thing has happened. And if you know the reason, then it will not happen again. The reason it happened is the valve was there for a little longer time, the cardiac output was low, we had a prolonged pacing run.
Ejection fraction 40%?
Yes. Let me come back to that point. That's why in the Euro PCR session, we showed that a mild paravalvular leak is also associated with more mortality at 7 years outcome. So if you can get rid of mild to trace and trivial safely without compromising mortality, you should treat that mild to moderate paravalvular leak.
I have an experience. The first case which was done by Alan Riviere from India, that was November 2011. We took the patient from India, that was first from India. Apollo, we worked up in Apollo and in France. That was an Edward Sapien XT valve. We had a mild paravalvular leak about grade 1, and we left it. And within 3 days, 4 days, it was gone. So sometime during a follow-up, it is gone. So is it really good? Is it really important to chase this mild paravalvular leak or not? What does the data shows?
In a young patient, we should, sir, 2011 to 2025, everything has changed. The valve has changed, the device has changed, the techniques have changed. But now we cannot leave mild paravalvular leak if you can treat it safely. So that's a caveat. You are not doing a post-dilatation with a calcified boulder at the LVOT and annulus.
Okay, thank you.
The double tap method is also excellent. Rather than going with a high pressure, oversized balloon, the double tap also really reduces the leak. That is also the essence of the case.
That's why this was an eye-opener for us. It's the first time this case we are doing, and we were surprised with this area.
Just to point out, if you actually saw the deployment, post deployment, that's what we call differential expansion.
Yes.
So on the right side, the valve is actually foreshortened. On the left side, the valve is not. That would be an indicator of double tap. The other thing is that puts up the other slide. Just pay attention to the annulus side, which is about 376, and what the actual achieved dimensions of the valve are.
Exactly.
You were still undersized relative to the annulus despite the double tap. So just keep that in mind.